Honorable Chairperson and respected audience, uh, for the first time, I'm presenting a case here. First of all, I would like to give thanks to Dr. N. Khanna for inviting me to present my case. Now, killing much time, let's come to the point. We're going to present a case of slipping of stent graft during stentum coarctation of aorta. This is about a 20-year-old female who presented with headache. On examination, the blood pressure in the right upper limb was 210 by 98 millimeter mercury. In the left upper limb, it was 100 by 92 millimeter mercury, and the both lower limb pulses were not recordable. Aortic pulses were present in suprasternal area, Soijman sign was present. Apex beat was localized in fifth intercostal space, having character. Biochemistry was normal. Chest X-ray was showing a sign of 3 with rib notching. ECG was showing left ventricular hypertrophy with stent pattern, and echo was suggestive of normal systolic function with diastolic dysfunction. We went for transradial on the right side with the help of 6 French femoral sheath and 5 French pictal catheter were positioned in ascending aorta, and ascending aortic angiogram was done. On the right femoral side, we took a 6 French femoral sheath. GR4 guiding catheter was taken, and with the help of thermohydrophilic guide wire, coax segment was crossed, pressure gradient was assessed. Then, with the help of thermo exchange length wire, GR was crossed for the coax segment. Later on, we take the help of the exchange length hydrophilic aquatrack wire, but somewhere they were not able to park the wire in the sink aorta. Then we removed the wire and took another wire that was super stiff, long exchange length, that was employer wire. Now we're trying to, since the coax segment was very tight, we're trying to dilate with the balloon. On the third dilatation, they will rupture the balloon. Then we remove the 6 French sheath which was originally there, and we take the 12 French 80 centimeter long Cook sheath, and we again dilated with the Optra probe balloon to 18 atmospheric pressure. Now we, since we could sense that now we can stent the coax segment, we thought for to stent the lesion. Now we chose Adventa V12 nitinol stent, but when we are deploying the stent, suddenly we realized that there was slippage of the stent. The problem was that this slippage might, if the slippage would have been inadvertent, that could totally kill the whole procedure. That's why. What did we do? That we just push the sheath, then we try to engage the distal end of the balloon inside the sheath. Again, we try to inflate the stent. Now this time, we could prevent the distal migration of the stent. And finally, we dilated the coax segment, and then seeing not much adequate post-dilatation, post-procedural success, we thought to go for the repeated dilatation with a non-compliant balloon. And this was the final picture, which we believe that the procedure was satisfactory. There was no compromise of the other carotids or the subclavian, and later on, the blood pressure in the both in the right upper limb, I believe, was somewhere around 140 by 100, and the lower limb, it was 156 by 100. And this was the final legend. Thank you.
Thank you very much. I personally really appreciate this case. And this case draw attention on the way to stent or stent graft the thoracic aorta. it's not an easy procedure, it's not an easy maneuver, and at the early beginning, and we'll still do that. We still do that for thoracic stent graft, for aneurysm, but also for TAV, beta blocker, adenosine, or rapid pacing, just to diminish the pressure in the aorta. What is your experience with this adjunct in order to have a safer implantation of the stent in a very high pressure? Or maybe somebody can do a comment.
Just to lower the pressure, you deploy the stent, or do you do something to reduce cardiac output? That's what he's asking.
Cliff, do a comment.
I think what Dr. Bousquet was asking is, do you do anything to lower the pressure in the aorta when
Yes,
you deploy it?
during the procedure, we started so the patient to low, yes, we started the patient the low infusion rate of the NTG, and it was kept at 1.2 ml per hour to bring the blood pressure to a normal level.
Cliff Buckley, what do you do personally?
We use either rapid atrial pacing or there's a dual balloon that you can put in the vena cava that it actually goes up and it can obstruct both the superior and inferior vena cava, or one or the other, by inflating it. And this really reduces the forward cardiac output substantially. And you can run the pressure down to about 60 with that. And then as soon as you let the balloon down, it picks right up again.
Who on this panel has the experience of stenting or stent graft coarctation? Michel? Cliff Buckley got also. Give a comment.
No, I don't have any other comments. I did some coarctation like that, and with self-expandables, with balloon expandable stent or cover stent too. And it's sometimes difficult to be very precise. And
As a former cardiac surgeon, I've been using open technique to treat these patients. Some of them were very young, some older with hypertension. I know, for having seen the lesion, that the tissue are very fragile, and this is a place that I wouldn't oversize or do some very difficult maneuver because it's embryologic. The tissue are very weak. Do you confirm, Cliff?
That's the reason it's maybe better now to place a cover stent or a stent graft than a balloon expandable like Palma. But cover stent is, I think, is better.
Yeah, we don't do bare metal stents. We use covered stents of some kind. Or a short segment stent graft, one of the short grafts.
Right.
Thank you, sir.
Can I have a question? Yeah, comment? Yeah. Short comment. Yeah, short comment. We don't, if we want to put the stent, wherever covered stent or balloon expandable covered stent or bare metal stent in coac, we don't pre-dilate. Directly, if you will pre-dilate, then more likely to sleep the stent, as it has happened. Yes. And so we don't pre-dilate. Direct stenting should be done. And then you dilate with the Atlas high pressure balloon, which takes pressure up to 30 atmosphere. And during pacing at 220 beats per minute.
Thank you for your comment. The last question or comment, 30 seconds. 30 seconds.
I'm Dr. Vinay Krishna. Actually, this case was done in Cardiology Institute, Kanpur, with the help of Professor Khanna. And Professor Khanna. This case was done over there. And because of the risk of this rupture, we always keep the patient ready for cardiopulmonary bypass also. So heart-lung machine, everything was kept ready. And we have done 2 cases with the help of Dr. Khanna in this way in Kanpur.
Congratulations. We have to go on. Michel, do you want to introduce the next case? And thank you, sir.
Thank you.